Firstly, hello and welcome to the 22nd meeting of the Biomedical Scientist Empowerment Education Discussion Group. So let me introduce you to our speaker for today. Daniel has joined us. Daniel is a principal biomedical scientist in the Special Haematology Red Cell Laboratory at Viapath Guy's St Thomas's Hospital in London. His main interest and expertise is in screening and diagnosis of hemoglobinopathies. His experience encompasses both protein and DNA-based techniques. Daniel completed his initial training in Portugal before moving to London, where he completed his MSc in Biomedical Science at the University of Westminster. Besides actively participating in several projects involving hemoglobinopathies and hemoglobin studies, he is involved in the training of all levels of scientific and medical staff as a training lead for the Special Haematology Lab. While I was doing my IBMS specialist portfolio in Haematology and Transfusion, I also had the opportunity to be trained by Daniel and his dry humour. In addition to his laboratory role, Daniel also lectured at the NHS Sickle Cell and Thalassemia Screening Programme, Training Days, Annual Sickle Cell and Thalassemia Conference, the South Thames Sickle Cell and Thalassemia Network, and as some of you may remember, he also presented at IBMS Congress earlier in the year. So over to you, Daniel.
Thanks very much. Indeed. So first of all, I wanted to thank you, for this group, especially Anas and Daniel, for inviting me. It's always nice to be participating in this, and especially having the opportunity to, in a way, go back to the origins, which I've worked in blood transfusion in the past as well. So linking both areas, which I really like, will be very interesting, and hopefully I'll meet standards that are said to me instead of that part of the dry humor, which I have no idea what Anas is talking about. So we'll start sharing my screen, so hopefully you will be able to see it. Now, thanks very much for the housekeeping rules as well, Anas, but in a way as well, being in this discussion group, which was one of the main things that made me excited to present in this group, is also you can participate. I'm actually counting on it too. Don't worry, I'm not making a list of people's names and then search in the net where you work and send your answers to your managers or whatsoever. So do feel free. I'm not expecting the right answers. I just wanted to have the discussions, which is basically the main purpose of this group. As I said, feel free to just pop in the chat or raise your hands, and the guys, the hosts, are keeping an eye. And you can ask questions throughout the presentation, which will make much more fluid. Anyway, your questions will definitely be some questions of other participants, so we can do everything together. So yeah. In regards to me, love training providing whichever settings, medical or scientific. So thank you very much for the invite yet again. So before we actually get into the presentation itself, and as I've been asked to link it as much as possible with blood transfusion, it's impossible for me not to go through a bit of the basics of hemoglobinopathies, because as I've worked as well in blood transfusion, you've always been bombarded with other clinical details which you might not be that familiar with. Disease states is like sickle cell anemia, sickle cell disease, beta thalassemia intermediate. So for you to have a grasp of understanding actually what that effectively means, the best thing to do really at this point is for us to go through a bit of the basics of how the diseases appear in the first place, how the hemoglobin is synthesized, where it's formed, and which genes are involved. So we'll go through that in the beginning as an introductory. Don't worry, I'm not going to bore you to death with slides and everything, but it is very important for you to understand, even when you are working blood transfusion, to have that beginning of an understanding of hemoglobinopathies. It will help you greatly as well. Then many of you, I'm certain, you are also participating in some kind of shift work. So you're doing out of hours, you're working night shifts, which means that in some settings where you work, I'm sure you need to give some sort of result. If a patient came through emergency departments and the doctors need to know right away if the patient is a sickle cell disease or not. There's mainly two techniques which are used and which I'm going to discuss as well, and I'll go through what's the pros and cons for that settings are, and then yes, it's going to be the fun part, which is the case discussions, which is the hemoglobinopathies, how do they look like, and especially linking in a transfusion laboratory setting. So as I said, let's go through the baby steps first. So hemoglobin synthesis and formation. It's important to know how the hemoglobin is formed, because it's from that stage you know which genes are involved. I'm not a geneticist at all, but just the basic understanding of which genes and how many of them you have actually is quite helpful, because it will make you understand what the end product will be, and if there is a disease in any stage, you will be able to know which hemoglobins are affected. So as we all know, we all have two chromosome 16s, which have two alpha globin genes in each chromosome. In the same way, we have two chromosomes 11, which each one, we'll just focus on these ones, are going to have beta genes. So these are the ones that we need to remember quite closely, especially in relation to blood transfusion. We have another delta gene and two gammas. Effectively, what that means that as any gene that is present in a coding region is going to be transcribed into mRNA and then translated into amino acids, peptides, which the end product is going to be proteins. So in the beginning, alpha, and it's quite easy to remember as well, because you have alpha globin genes which produce alpha globin chains. In the same way, you have beta globin genes which produce beta globin chains. Delta genes, you guessed, delta globin chains. In the same way, the gamma genes produce gamma globin chains. So you know exactly, and it's quite easy to remember because you always go back to gene, the name of the gene, and which is going to be the corresponding peptides. Now it's puzzle pieces. You're basically playing with Legos now. When you associate alpha globin genes and gamma chains, beg your pardon, you're going to form hemoglobin F. So F is produced by alpha chains and gamma chains. F stands for fetal. So it's going to be the main hemoglobin present when the baby is born, and obviously before as well. So this is the one is going to be prevalent when on the stage of delivery. Then if you associate alpha chains with beta chains, you form hemoglobin A for adults. And as the name is already giving you away, it's going to be the main hemoglobin present in adult stage. And then delta chains are going to be associated with alpha chains, which is going to form hemoglobin A2. Now, hemoglobin A2 is quite residual in many times. It's not as important because it's not one of the main hemoglobins. In fact, when you're talking about adult stage, it's just it's basically just around 3% of your total hemoglobin content, so it's quite low. So his main purpose really is not as a physiological purpose itself, but it's much more for diagnostic stages, and we're going through that later on. But the most important part here for you guys to remember, because we in blood transfusion, we might even transfuse babies that are not even born, but also babies that are just born if they have some kinds of clinical settings that such require. But the important part is as well for you to remember that the adult phenotype, the adult hemoglobins, or the percentage of hemoglobins, is reached quite quickly on the lifetime of a child, because it's around 9 months. We usually say around 9 months to 1 year to be on the safe side. But really, when you are 1 year old, you already have the same picture as you should have throughout your life, because all your main hemoglobins are already present, which again is going to be hemoglobin A and hemoglobin A2. You have, or if you have any hemoglobin F, it's going to be quite residual, because the switch between hemoglobins is, as you can see, quite rapid. And again, between 9 months and 1 year, you almost have no F if you don't have any hemoglobinopathies. So you have no abnormalities on your genes. Now, there's really two techniques that are used in routinely screening of hemoglobinopathies, mainly more in out-of-hour settings or night shifts. Really, either you have an automated system which is going to perform the analysis for you. I will say that one can be automated, another one is going to be manual. one that is more standardized, at least here in UK, especially in London, is HPLC analysis, which stand for high performance liquid chromatography. So obviously you can have different types of analyzers, different manufacturers. You could even have a different principle, being the one that separates hemoglobins, like capillary electrophoresis, the CEV analyzer, which some of you might be familiar with. So either way, it's going to be an automated system. Then, on the other hand, which we're going to discuss next, it's going to be something very quick, very manual, which could be as simple as a Sickle solubility test, which is quite simple and give you an answer straight away. So the first we're going to cover now is what we have, and is not many hospitals, I must say, that have these settings for night shifts as well, but you're going to see what's the advantages of having one as well. So in high-performance liquid chromatography, I did say I'm not going to bombard you with slides, but I'll give you nice videos as well. How nice of me. So in regards to chromatography, you always, the basic principle, you're going to have a mobile phase, but also you have a stationary phase. Mobile phase really is it's going to alter the sample in a way, but mainly it's for transports. When you're injecting blood, you can imagine that you have so many, it's so heterogeneous type of sample. You have cells, you have lipids, you have proteins, you have everything there, but you only want to focus in one single protein, which is hemoglobin. So how are you going to do that? So that the magic happens, how hemoglobin behaves when it's inside that mobile phase or the buffers that transport it. Because in especially the principle I use for the BioRed analyzer, when hemoglobin is in contact with that buffer, that mobile phase, it acquires a net positive charge. This is key, positive charge. Because then on the stationary phase, or the column, or basically where the hemoglobins are going to be stuck and captured, is going to have a net negative charge. So you can see, basically playing around with charges, if the hemoglobin is positively charged, it's going to be stuck on the polymer, which is negatively charged. Everything else, everything which is not necessary for analysis, just going to fly through, and we're not going to see that on the analysis itself. So that's essentially it. If you focusing just on the hemoglobin, then you have several of them. So how are you going to separate them efficiently to be able to see them in separate peaks, in separate electrophoretic panel or electrogram? So that is done by the properties of each hemoglobin. Although all of them are hemoglobins, they have different charges. Some are more positively charged, some are less negatively charged. So that difference of charge will mean that they will elute differently in different times. So a typical analysis for an HPLC plot chromatogram, each sample takes 6 minutes. 6 long minutes if you have someone shouting on your phone asking for a result ASAP. So it's always important for you to set a realistic time frame on how you will be able to give the sample. I'm not even mentioning calibration or QC necessary to run beforehand, but usually and typically speaking, HPLC takes long because it needs to have time to separate hemoglobins. So that's all well and good. So you manage to separate the hemoglobins. You wish you have only normals, but then you're bombarded with lovely pictures, and then during a night shift, probably at 3 a.m. in the morning, which you haven't had your coffee yet and barely had a minute to rest, you're being asked to interpret these lovely pictures. So it depends how you go about it, but I'm sure, and I do hope, that many places already have a certain protocol or settings which will be able to guide you through. Because in out of our settings, you're always being asked to look at what is significant and what is emergent. Usually that always goes around hemoglobin S, isn't it? But essentially, you never know what you're going to get, and you might get one of these pictures. And usually, the reaction is always the same. This is the point which focusing on the right hemoglobins, focusing on what I'm been telling you today, like what is necessary for you to be focusing, and especially which genes could be affected, that is the main idea they need to take out of it. So that's HPLC. Now, talking about one that is very much used in many hospitals, again, here in UK, in London specifically, which basically is the main experience I got, The sickle solubility test is quite a basic test if you look by comparison. Firstly, is completely manual. The only thing you need is an EDTA sample provided to you, which could be the same as full blood count, obviously. Now, the reagents itself are quite basic as well, because they are really just separated in a couple of components. In essence, is a phosphate buffer solution, which you're going to put, usually, depends on the kits that we're talking about, but usually around 20 microliters of blood. Well mixed blood, quite important to note as well. So inside that solution, you have something very fancy called sodium dithionite, which is a reducing agent. I'm going to tell you what it does in a minute. Saponin, which is standardized in many techniques, usually more towards the older techniques, but essentially just is a lysing reagent. So a reducing agent, and taking into account the name of the test itself, sickle solubility test, the main purpose of a sickle solubility test is to look for sickling hemoglobins. Now, careful what I'm saying here. He's looking for sickling hemoglobins. I'm not saying that he's looking for S. Although, obviously, statistically, 99% of the times you're going to do a test and it's positive and you identified a sickling hemoglobin is going to be hemoglobin S, it's not necessarily going to be all the time. We will focus on that 99% of the times. So that reducing agent is basically going to force the hemoglobin S, if present, to sickle. So what happens? If a red blood cell contains just normal hemoglobins and doesn't have hemoglobin S or a sickling hemoglobin, due to the effect of saponin, the lysing reagent, is going to lyse that cell. So all the content of that red cell is going to be released to the medium, and it's going to have a transparent appearance. So you're going to be able to see through that solution. However, in the other hand, if there is a red cell that contains hemoglobin S, it's going to resist that lysing because the reducing agent force it to sickle. In a sickle shape, is going to be much more resistant to lysis and is not going to lyse. So therefore, the appearance of a positive sickle solubility is going to be a turbid sample. So here we have some examples. So as you can see, the first couple of tubes are going to be QCs, which is quite easy to see. The reading, so it's quite fast as well. You're going to see, if you are able to not see the lines that are behind the tube, that's a positive result. However, if you are able to see the lines through the solution, that's a negative result. And here are some couple of patients, and you can see that the majority of them are positive. But that's the take-home message, that the sickle solubility is going to give you my indication that it is hemoglobin S. It seems quite easy, isn't it? So why should I bother in going around an analyzer, which most likely is not going to be near me on the blood transfusion department? I need to find the samples, run QCs, possibly calibrations, maybe look at reagents, run it. Each sample takes 6 minutes to run. So really, realistically, we're going to have a result possibly around just after half an hour or 40 minutes. So why doing this? So it's really, in this stage, that it's important for you to compare and contrast, because the pros of a sickle solubility, as I said, is very straightforward, very simple test, and it gives you a quick result. Around 6 minutes, including setup, pipetting, reading, is going to be quite easy. Usually the reagents, either by the lab that is responsible to it, or even the manufacturers made it so easy that the reagents are already made up, so it's quite easy to use them. And usually cost effective depending on how you, which kit you use. Now, the cons, though, and that's important to know, and quite important even when you're in blood bank, because yes, it tells you that there is hemoglobin S most likely there, but is it a carrier? Is it a homozygous? Is it a compound heterozygous? Is it any disease? Literally, the only thing that this test tells you is that that blood has hemoglobin S. It doesn't tell you in which severity, if you want. It doesn't tell you anything on that. So it also has the downside that there is a sensitivity cutoff. So really, you should not be doing a sickle solubility if you use the previous method, obviously, which the hemoglobin S is less than 10%, because it's going to be bound to give you equivocal results or even false negatives. Hemoglobin F, so if the fetal hemoglobin, in many ways, physiologically is quite beneficial, but F inhibits the polymerization of hemoglobin S. It inhibits the sickling process in a way. So if you have lots of it, even if doing it in vitro as doing in this test, is not going to give you a right answer, because it's going to inhibit that process, even when the reagents are inside. So especially in neonates or really young children before the age of around 1 year, we need to be very careful if this is the first line of testing that you've done. Now, we have discussed that, so therefore, but the main sticking point is that the sickle solubility doesn't provide you with the phenotype or the genotype, if you want. So is it sickle or is it not sickle? Is that really the question that the doctors or nurses or even colleagues of yours are asking you to give an answer to that question? So in both methods, you have pros and cons, and then sickle solubility is not going to give the answer if it's a sickle cell carrier, a disease, or any other type of disease. So we'll focus on HPLC because I want for you to grasp the benefits of it, and especially when you're doing out of hours and doing night shifts and you don't have that much support of people that maybe know this technology better, you want a simple system that is going to give you the right answer and provide the best care, especially around blood transfusion. So I'm going to start with this case. So what I'm going to show you is essentially the end result of an HPLC chromatogram. This is it. It's basically giving several peaks, which also gives you a table, an interpretative table, which is going to give the percentage of every single hemoglobin component that is detected. For instance, so this particular chromatogram has said that this patient has 0.5% of F. It has 49.5 of A, 3.2% of A2, and a hemoglobin S of 38.3. I always put the full blood count results with it because hemoglobinopathy testing and screening, you cannot go one with the other. You always need to have both always together. So that said, I also wanted to let you know, because sometimes you've been asked that question possibly, is that sickle cell carrier, just the mutation causing the sickle cell carrier status, doesn't give you low red cell indices. It might have other things going on, like iron deficiency or some kind of thalassemia that will diminish the red cell indices. When I say red cell indices, I'm mainly focusing on the MCV, but especially the MCH. So, but the sickle cell carrier itself is not going to give you low red cell indices. So, following the guidelines here in UK, we have the sickle and thalassemia screening program, which releases and reviews in a regular basis between 3 to 4 years every time, and the guidelines for screening for antenatal especially, but we can basically use the same for other settings. So if you've done HPLC and you have the appearance which is in front of you, you always need to do a secondary line of test to confirm the abnormality that you found. So on this chromatogram, I found 38.3% of hemoglobin S. So therefore, I need to do a sickle solubility test. I could do other things, but as you saw, sickle solubility is so fast and easy and cost effective. So if it gives me a positive result, linking both technologies together, I can comfortably say this patient is a sickle cell carrier. So I use the term carrier, but I'm sure that many of you have read or even been trained using the terminology of sickle cell trait. The trait terminology is actually falling a bit in disuse, and you're going to see in publications or even books coming up these days, even Barbara Bain's books always now says just carrier. Now, that's good. Just to emphasize here, you had hemoglobin A, right? So if you had hemoglobin A and it's more than hemoglobin S, that's which really gives you the confidence that this is just a sickle cell carrier. So in emergency settings, if you are able to give this information to the doctor or nurse, you're instantly going to give them no worries for whatever the procedure the patient is going to be, because the sickle cell carrier management in, for example, pre-op setting, this anesthesia is going to be basically the same as a patient with a normal hemoglobinopathy or no abnormality at all. However, things change a lot when you don't have any hemoglobin A. So this is really one of the main pictures that you're not necessarily going to see when you're working blood transfusion, but is mainly the one that you're preparing humongous amounts of blood every time. So here you have an F of 3.6. A is not detected, it's not present. Na2 had 3.3%, and you can see the amount of hemoglobin S that was detected, 88.1%. Could be even higher. So, and red cell indices, again, patient is clearly anemic, so that already gives you a pointer. And the red cell indices in regards to being low could be other things, but this is after obviously doing a secondary line of confirmatory testing, like a sickle solubility test, gives you the diagnosis of a sickle cell anemia or a homozygous hemoglobin S. Why homozygous? Why does the patient not have any hemoglobin A? So if you remember the first slide I've showed you, when hemoglobins have been formed, it means that the two beta genes that the patient has are mutated, have the sickle cell mutation in those genes. So therefore, the only thing that is actually producing when in conjunction with the alpha change is literally just hemoglobin S. It doesn't have a normal beta chains to form normal hemoglobin A. So that's all it produces. And this is really where the clinical significance come from, because one of the main things I've been asked is not all sickle cell anemia patients are transfuse dependent. If that will be true, I'm sure your departments in blood transfusion is going to be triple the size, because to be able to, or if there was a necessity to transfuse every single patient with the sickle cell anemia, you will not have capacity. The blood fridges that you have will be definitely the triple the size, especially because the amount of blood you're transfusing this patient if they are on a regular transfusion program. So when do you know if a patient needs to be transfused or not? So in a way, thankfully, this decision is not made by us. Although we have all results in front of us, we don't have all the story. We don't have all the history of the patient, clinical history, but we don't physically examine the patient either. Because one of the main things that clinicians, hematology consultants, or SPRs look at the patient when you're thinking or putting the patient on a regular transfusion regime is how well is it faring without it. In other words, there is protective mechanisms that will patients not be prone to much more of sickling and sickle cell diseases and tendencies to emergency departments. One of them is the amount of hemoglobin F. As I said, hemoglobin F has a very protective effect on these cases, because not only it inhibits the polymerization of S, so it inhibits the formation of the sickle cells, but also it's a normal hemoglobin, so it's doing its job in providing oxygenation to the tissues, so it has a double whammy effect. So that's one of the things, but it's a clinical decision because it's so many factors you need to look at. So for example, if a child had a stroke, if the child hasn't been on a transfusion regime and he had a stroke or any other consequences, clinical consequences because of the disease state, he most likely is going to be put on a transfusion regime just to prevent it to happen again, because stroke is quite something serious. Even if he didn't have many effects in a way, the possibility of reoccurrence is quite much more higher. So therefore, the best way to prevent it, or the best way now, is to put the patient on a transfusion regime. So that clinical decisions, those little bits of information required is necessary, and putting all the picture together will mean putting or not a patient on a transfusion regime. Now, other things, like for example, the sickle solubility is not going to tell you. It's compound heterozygous. It's quite a mouthful, but effectively it just means that instead of having just hemoglobin S, you have something else. Yet again, both beta genes that you got, they were mutated, but not for the same mutation. One has been mutated to produce hemoglobin S. On this case, another one has been mutated to produce hemoglobin C. There are several hemoglobin variants. In fact, last time I've checked, which was 6 months ago, so there was more than 1,300 hemoglobin variants just for beta and alpha genes. So there's a lot. Combinations are almost limitless. But on those cases, which I'm presenting here, is the most common, yet again, here in London, which you're going to see. So SC is actually something quite common as well. But yet again, do the patients need transfusion? Not necessarily. In fact, the majority of cases will not. So on these cases, you can see hardly had any hemoglobin F. The A was not detected, but he had more or less in even proportions S and hemoglobin C. Red cell indices are affected, but they are not affected because of these two mutations. Most likely these patients, because he has a low MCH, low red cell indices, most likely the patient had a bit of maybe iron deficiency, but most likely possibly a thalassemia, alpha thalassemia to be more precise. So the sickle solubility you need to confirm, which is going to confirm the presence of hemoglobin S, but C, hemoglobin C, needs other methods which needs to confirm it. Could be something as simple as a gel electrophoresis up to DNA analysis. There's several ways you can confirm it. So when you have done that, you can give the diagnosis of FC disease. And yeah, so the majority of cases are not transfusion dependent, but there are cases that are. Yet again, it's going to be a clinical decision in what has happened to the patient. Yet again, best example really, if for some reason the patient had some clinical manifestation, had a stroke, for example, therefore most likely is going to be put on a transfusion regime. Now, I want also for you to understand, because it's quite easy for us to be on blood bank, which we are bombarded with hundreds of samples per day, most likely, and look at the clinical details and not maybe pay as much attention as we will need, simply because of the amount of samples we got, about when these little 3 words appear on a request form. Sickle cell crisis. Firstly, what is it? Is a basic one of the most severe stages when you are sickle cell disease that you can get. And essentially, what has happened, so as you know, inside the blood vessels, you're going to have red cells. The red cells that hemoglobin S, contain hemoglobin S, but attention, only contain hemoglobin S or some other hemoglobin variants, because carriers don't usually do these, neither normal patients. They sickle. By during the sickling process, the red cells become so much more rigid and they are not as flexible to go through the microcirculation, the capillaries, so they get stuck in the blood vessels. All of that is just caused by one little mutation in the genes, as I showed you before. So it's just one nucleotide that has been changed, so A to T, which means the amino acid produced by that mutation is going to make the hemoglobin polymerize. It's going to create big, long filaments inside the red cell, pushing the boundaries of the red cell, making it sickle. So that is a sickle cell crisis, but very important for you to understand is that if the microcirculation is blocked by the sickle cells, there's no blood supply. So whatever that blood vessel was giving nutrients and oxygen is not going to get them. So therefore, the extreme pain that comes with it is not uncommon to see, even maybe in clinical details when you see the request forms, is bone pain, is sometimes related to the brain as well, or any organ that needs a lot of blood and has a lot of capillaries is going to be the first ones which might present clinically. But bone pain, because it has so many small filaments and small capillaries, is going to be quite a common type of pain described by patients with sickle cell disease. Now, you guys come to play. The same patient I showed you before is the first plot on the left, which as we said, the majority of it was 81% of hemoglobin S. But then you get a lovely request in your lab, and he's asked to produce possibly around 7 to 8 units, depending obviously the page, the weight, the age of the patients, and the requirements, and how clinical severe it is. But it's more or less how many units are requested, I will say, and then they are transfused, and usually they take a pre-transfusion sample for us to do a hemoglobinopathy screen, and a post, because obviously they want to see how much the S has dropped. On this specific case, you can see that when there was no hemoglobin A present in the first case, after transfusion, you're just given the patient 74.7% of hemoglobin A normal. So hemoglobin A2 is just 2.8. S has dropped from 88 to 8.3. So really, this is the benefit that they want to give to the patients. But in the same way, when I was describing putting or not a patient on transfusion regime, as you all know, transfusion is not without its risks. I'm not even mentioning transfusion reactions itself, but the long term, because you need to remember, once the patient is on a exchange blood transfusion program, is a bit complicated to take it out of it. So if you're depending to give that patient now every 3 to 4 months another exchange transfusion, 3 to 4 months every year, decades, maybe throughout the life of the patient, you can just imagine how much that has an impact on the patient itself and his lifestyle in a way. So it has that consequences. Another thing I wanted to say is that this actually is an actual case. So yeah, great. You dropped the hemoglobin S to 8.3%, but all of a sudden you start to have hemoglobin C there too. So just for me to rest my voice now and given us some work, I don't want him to be bored. If you want, either say it or type it on the chat. What will be the reasons that all of a sudden, after this patient has been transfused, the patient has C, hemoglobin C of 1.6%? I'm open to any suggestions at all. I hope you guys are not too shy.
So Daniel, we've got a couple of answers in the chat. So
Good.
one person said it's interference. It could be interference. Somebody else said, could it be from the donor blood? A few people have said it could be from the donor blood. The donor unit was HPC positive.
Now, another question, and I wished I had a patient blood manager on the call. How are units, or people that work in NHS which is the blood service here in the UK. So how are units screened if they are hemoglobin S positive or not? Which technology is used? Which method is used? Do you guys know? Any answers on us, by the way?
So somebody just answered HPLC. A few people have answered HPLC. IEF as well. Isoelectric focusing, HPLC again.
Last time I've checked, it's a sickle solubility. I'll be surprised if it has changed. Anyone working in NHS do feel free to correct me. But last time I checked, we know one of the heads consultants over there was a sickle solubility. So can you see the reason why I showed you the difference between HPLC and sickle solubility test? Doing a sickle solubility provides you the most important information when you are selecting blood units, because many times on this, it needs to be HBS-neg units given to these patients, obviously, because you don't want to give hemoglobin S, the patient already has it. It's counterproductive. So a sickle solubility will tell you exactly that. Is it hemoglobin S negative or is it hemoglobin S positive? So doing HPLC, you will be able to pick up not only if the patient is a hemoglobin C carrier or any other variant carrier status, right? But they're not. So therefore, they are validated as blood donors, and therefore they can give blood, thankfully. And yeah, sometimes you're right, guys. The hemoglobin C present here was due transfusion. So a blood unit was from a patient that most likely is a hemoglobin C carrier. So those interferences do appear here, and in such a form. So just for you guys keep, and also I wanted to show you what's the difference of what you do when you're providing all of that blood to the patients. Now, more quickly now, beta thalassemia is a bit of a different story, isn't it? Because it's not an hemoglobin variant, it's not hemoglobin S produced, it's just, again, hemoglobin A2 here is crucial because it's a diagnostic point. If it's higher than 3.5 here in the UK, you start to wonder if the patient has beta thalassemia on carrier status, okay? So the low red cell indices are quite typical. The raised A2 is basically one of the most basic forms of hemoglobinopathy to diagnose because you don't need to do any other confirmatory testing. Low red cell indices, raised A2, it is very likely that the patient is a beta thalassemia carrier. So why is it important? On a carrier status, you will never see them to be transfused. However, when the patient has no A and has a lot of F, and the A2 on this case is 2.3, but I want to point it out, this is a newborn patient, so the patient was not put in a transfusion regime. The patient are chronically anemic, really low red cell indices, and many times the diagnosis is beta thalassemia major. So not that term you have heard several times, most likely on your transfusion departments, because it is a transfusion-dependent thalassemia. You're going to hear these terms quite more frequently as well, because T and T or N DT, so transfusion-dependent thalassemia on non-transfusion-dependent thalassemia. It's a terminology that's coming up quite more frequently, especially on transfusion departments, because it's distinguished what needs transfusion for life support to carry on to be alive, essentially, or actually doesn't need, it might have clinical consequences, but it doesn't need transfusion normally to manage that situation. So here, what has happened? What has happened to the genes? What has happened to the hemoglobins? So taking this example as well, taking exactly the same genes that I've talked initially, you have two beta genes, one in each chromosome 11. So they've been affected by a beta thalassemia mutation. There's more than 320 described in literature, and some of them are severe enough to switch off completely the production of beta genes. So therefore, the only thing remaining that you have are gamma genes, delta genes, and alpha genes, which are going to produce the corresponding chains, which puzzle pieces, ta-da, hemoglobin F and hemoglobin A2. But the most important here to know, thing to note here is the absence of A. And you saw the patient was chronically anemic, so most likely this patient is going to be transfuse dependent for life. Now, complete switch in testing, if you want. Another thing that I like to see, or people usually ask me, is I think I'll go through the case as it is. So, in a lovely Friday evening, as it happens every time, you get group and safe, a sample and blood transfusion, not necessarily requesting for a cross match, but just a group and safe. A 29-year-old woman presented at 28 weeks of gestation, and it has fallen onto her abdomen, and she's probably feeling a bit of pain, but just to be on the safe side, she went to the hospital to check if everything was okay. So pregnant lady, 28 weeks, and group and safe most likely was requested, but as well, a lovely test, which we all love, called clay hour stain. After you've done it on a Friday evening, you see this lovely picture. So this has really two ways to go about it. Thankfully, the guidance and the guidelines and many procedures that I've seen actually are quite clear what to do anyway. But it seems that this Kleihauer is positive, which is in keeping with the clinical details too, because might have suffered some of fetal hemorrhage. After being counted, it says that's around 0.9 to 0.4 fetal cells, which will correspond to a 54 mil fetal maternal hemorrhage, FMH. This is actually a case from Canada, which has been sent to me. So it has happened. So, okay. Usually here in UK, as long as I remember, when you have a picture like this, if it is a Friday evening, the procedure is quite clear. You need to send it to do flow cytometry, because essentially you need to separate out, is these fetal cells which I'm looking at my Kleihauer actually from the child itself, or are they not? On this particular case, they were not. So it's quite an interesting picture, isn't it? Because there's lots of them. But when you do flow cytometry, and I need to remember you guys, it is quite a sensitive and specific test only for the fetal cells. You have found none. So the question lies, where did those cells come from? I mean, sending Kleihauers and actually they're coming as negative. As for, just for comparison as well, this is actually another case, a bit older, and pretty much the same picture. The Kleihauer was quite positive, and the sample was sent for flow cytometry, and he actually measured 4.2% of cells. That actually is quite a lot. So therefore, this is the right thing to do. You need to measure it on a method that is sensitive and specific enough to actually distinguish which the fetal cells came from. So now to you guys, have you ever seen this picture? Has it ever occurred to you? And do you have any idea why this has happened?
Danny, we've got a couple of answers to your question, but before we get onto those, I think there was a question regarding your previous case regarding the HPC, and somebody asked, does the HPC go away after a while? So while people answer this question, do you want to address that first in your previous case?
Absolutely. Thanks, Anas. Yeah, so the C will disappear as any variant that will be transfused. It will disappear as well, because as you know, the lifespan of a newly created red blood cell is 120 days, right? So obviously less when it's transfused, but it will dissipate. It will disappear. And also to note, thank you for bringing that up, is that it will have no consequences. One of the clinical rationales, so we say, that to keep sickle solubility is because even if the patient is transfused with a unit of which contains a variant which is not S, it's not clinically significant. The C itself is not going to do any harm to the patient or any other hemoglobin in that fact. 99% of the cases. Yeah, so which are the answers that people have provided?
So most people have said HPFH. The mother has HPFH. We've also got somebody that's raised their hand. Josephine, do you want to speak?
Please do.
Oh, thank you. I was just saying my chat's not working, so when I put the answers in there, it doesn't submit for some reason.
Oh.
It might just be an issue with your meeting instance. So if you try leaving the meeting and then joining again, maybe that will fix the chat issue.
Okay, thank you.
So, as far as I understood, many people said HPFH.
That's correct.
Really nice answer. So, what is HPFH in the first place? Absolutely, HPFH is a possibility. Whatever an antenatal patient is already described in literature, they might have some incremental hemoglobin F, completely normal. It's just because of the gestational effect itself, you might increase hemoglobin F of the lady itself, but not to humongous amounts like this case. This case, you have an F of 27%, which is very high. And the red cell indices, again, an HPFH will not affect the red cell indices. They will be normal. If they are low, it's because there's another reason for it. So yeah, you guys are absolutely right. It could be because of HPFH. There are others other hemoglobinopathies which will increase hemoglobin F, but HPFH here in London at least will be here in at least on the hospital I'm working, because even in London there's different areas which different pockets of populations will have other hemoglobinopathies more specific. But yeah, an increase of F. So it is interesting, isn't it? Because if you're working in a blood transfusion department, ask yourselves, is it part of your procedure to see if the patient's had an hemoglobinopathy screen? Is it part of the procedure to see if the patient by herself had a raised F before actually getting this request for a clay hour? Now, it's a very interesting discussion topic, which I'm more than happy for you guys to have as well, because will it make a difference in your procedure itself? Can you risk it? This patient that is an HPFH, he had that clinical details that fallen into abdomen. He might have had some pain. He might have had some bleed. He will go to the hospital. You guys get a clay hour to do, and it's positive. You are not able by the clay hour. The problem with the clay hour is not specific. He will not tell you because it's a microscopic technique. So by then you need to find a technique, usually flow cytometry, which is able to distinguish between one or the other. The procedure will be the same, but is a good case though, always to see the limitations of the techniques when you're doing them, because obviously it just makes your department more reliable. So with that, good in time. I just wanted to share, as I need to thank yet again to Daniel and Anas, because they already started to share before me. If you're interested about hemoglobinopathies in general, we have also created a YouTube channel for it. We are working on it, and we're going to release more material soon. The idea is to do it as frequent as we can, but obviously there's some constraints time-wise. But feel free to join, to share, and I'm not sure if Anas is allowed to put that on the chat as well, the link to the YouTube channel, or even I can do that afterwards. But yeah, it's something that is always good to link the knowledge that you got in blood transfusion. It was quite specific and actually quite acute and urgent to other areas. Hemoglobinopathies is always something that you're going to be exposed to because of the clinical severity, so therefore the transfusion requirements that you need. So that's the idea also to about this channel as well, is to give an understanding in a short videos of 10 minutes to understand better hemoglobinopathies and actually provide a better service on the end, really. So hopefully you guys enjoyed, and thank you very much for your attention.
Thanks, Daniel. We've just got a question at the end regarding your previous case about PFH. Somebody's asked, what is the incidence of HPFH in the general population?
Oh, the prevalence.
Yes.
Which population are we talking about? It's a good question. However, it's probably one of the things that you need to think about if you are going to change any procedures at all, is to look at prevalence of HPFH. I'm afraid that I cannot give the answer to that, especially here in London. The population is so mixed race and so heterogeneous that an HPFH affects the common types. There are 7 of them. So the most common ones are usually from Africa, Guinea, Kenya, but it really depends on the population that you have, and it's quite variable because usually here in London, you will not have an indigenous HPFH, so you're depending on to see where the patients that came from other countries. But in Africa itself, I'm sure you'll be able to see some information, which I don't know. What's the prevalence in HPFH, because I will imagine that it will be separated by the type of it as well. And do remember as well that Africa will not have the same diagnostic tools that we'll have. So it depends which guidelines they're following as well. But I'm sure they will going to be able to find something if you do a literature search about HPFH. But I can tell you that our service, at least in Guy's and St. Thomas, we will find, I will say, possibly around 15-20 cases a year, and those are new cases. So 15-20 new patients a year. It's not that much, honestly, but is usually, especially in blood transfusion, you're caught out in the low numbers, isn't it? So something to keep in mind.
Okay, we've just got one more question regarding the sickle solubility test. And you mentioned in your presentation that 99% is due to HBS. So what is the other 1% due to?
Probably I was giving too much percentage. Hemoglobin S is definitely the most prevalent, which you're going to always find that associated to the positive sickle solubility test. But there is other hemoglobin variants, which is, for example, HB Achilles. There's others ones, and especially if you're using a sickle solubility test, there should be a line there, at least on the main kits that I've used and seen and validated. There is on the kit inserts the limitations. It's going to say there's a couple of hemoglobin variants which are bound to give you a positive sickle solubility test, but it's not hemoglobin S. But you need to be careful with those though. These mutations, for example, HB Achilles, it has the mutation, the hemoglobin S mutation. The only difference that is a different hemoglobin variant is because it has two mutations. It has hemoglobin S and another one a bit more forwards in the gene, and that makes not only one different amino acid, it makes two. So therefore, the hemoglobin variant itself and its appearance is different. I must say, for all the years I've worked in hemoglobinopathies, I haven't found one yet. So it kind of tells you how rare they are. So I should probably say is 99.9% of the times you're going to have a positive sickle solubility. It's going to be hemoglobin S. But yet again, be familiar about the limitations of the test that you're using.
Thanks, Daniel. For all the other questions that were asked in the chat, we don't have time to get to them today. We'll, if it's okay with Daniel, we'll answer those questions via email. I'll hand over to Danny now to do the closing remarks for the meeting. Thanks, Danny.
Thank you, Anas. Firstly, massive thank you, Daniel. Really interesting, insightful, and well presented talk today. Really pertinent topic, and I think the attendance, almost 170 attendees throughout, just shows that it was a really relevant and pertinent topic. So thank you for giving your time today to come and join us, and also thank you to Anas Nasir, who has been a brilliant host for us today. Just once again, thank you, Daniel, thank you, Anas, and thank you for everybody joining us today. Really encouraging numbers joining this group month on month now. So we're really happy with that, and we're really interested in getting that feedback from you to continue to make this group what you want it to be and how useful you want it to be. So please do complete that evaluation form before you go, or as soon as you can. Lovely, thank you very much, and hopefully we'll see you next month. Thank you very much.
Thank you.